بسم الله الرحمن الرحيم. موضوعنا اليوم عن oral squamous cell carcinoma. In malignant neoplasm, oral cancer is one of the important causes of mortality and morbidity. Squamous cell carcinoma is the most common form of oral cancers in adults, and it's related to risk factors such as smoking and alcohol consumption. And it accounts for approximately 3% of all malignancies and more than 90% of cancers of the oral cavity and oropharynx. Okay, as we said before, the reported etiological agents and risk factor for oral cancer include tobacco use, frequent alcohol consumption, a compromised immune system, and also a histology of dietary habits that can cause cancer, as well as less established factors such as infection with certain types of human papillomaviruses. And it mostly affects adult men between the 6th and 7th decade of life. The most affected sites in decreasing order are tongue, oropharynx, lips, floor of the mouth, gingiva, heart palate, and buccal mucosa. Unfortunately, approximately 60 to 65% of oral cancer patients are in TNM stage 3 and 4, which means delay in diagnosis, which consists of either patient delay or a professional delay. Three patients with oral squamous cell carcinoma, along with the clinical and etiological findings, are described in this case presentation. In case number 1, a 52-year-old man was referred to the oral medicine department, complains of pain and swelling in his left mandible and difficulty swallowing. The patient's anamnesis revealed that during a 6-month period, he had been to 2 dentists in his own country, and they had implemented a palliative treatment such as the use of mouthwash and antibiotic therapy. And because of the late diagnosis, the lesion was fairly enlarged when he presented to the faculty. His medical history revealed that he had no systemic health problems but had been a smoker for 30 years. His clinical examination revealed a hyperemic ulcerated area with exophytic enlargement to the buccal and lingual sides. Because of his lack of oral hygiene, food debris had accumulated on the surface of the lesion and his tongue was hairy. He had an enlarged, painless, fixed lymph node in the submandibular area. A panoramic radiological evaluation revealed a radiolucent area and bone loss with irregular borders in the 3rd molar region of the left mandible. Upon an intraoral radiological examination, we observed a lesion approximately 6 cm in size. The diagnosis after histological examination of the biopsy specimen was invasive squamous cell carcinoma, and based on the histopathological evaluation, the lesion was deemed to be grade 3 level. On the basis of the clinical, radiological, and histopathological evaluation, they made the diagnosis of a stage 3 lesion. The patient was referred to an oncology hospital, and according to recently received information, the patient has undergone chemotherapy after surgery and is now in the control period. Okay, this is a 61-year-old man was referred to the oral medicine department. He complains of pain and swelling also in his left mandible. His medical history revealed that he had no systemic disorder. Also, he did not have any habits such as smoking or alcohol intake. The patient anamnesis showed that he refused to be examined for 9 months. His clinical examination revealed an ulcerated, hyperemic enlargement with an irregular surface in the retromolar region. He had no signs of the lymph node in the submandibular area. The patient's radiographic examination showed excessive bone loss, including the 2nd and 3rd molar teeth in the left mandible with irregular borders. Upon clinical and radiological examination, the lesion size was determined to be approximately 5 to 6 centimeters. The diagnosis rendered after the histological examination of the biopsy specimen was a well-differentiated squamous cell carcinoma at the grade 2 level. On the basis of the clinical, radiological, histological evaluation of the lesion, it was deemed to be in stage 2. The patient was referred to an oncology hospital. According to recently received information, the patient underwent surgery and was awaiting a decision regarding the initiation of radiotherapy. In this case, a 60-year-old woman was referred to the oral medicine department. She complained of continuous pain for 3 months after tooth extraction in her maxillary palatal region. During this time period, she had used the antibiotic given by her dentist. Her medical history revealed that she had hypertension and diabetes mellitus. She did not have any habits such as smoking or alcohol intake. Her clinical examination showed swelling in her palate with an ulcer in the center of the lesion and a pseudomembrane on it. Also, she had halitosis. The patient had an enlarged painless fixed lymph node in the submandibular area. A radiological examination revealed a considerable expansive area in which the margins of the radiolucent lesion could not be visualized on the panoramic radiograph. Upon clinical and radiological examination, the lesion size was determined to be approximately 7 cm. The diagnosis rendered after histological examination of the biopsy specimen was invasive squamous cell carcinoma with the grade 3 level. On the basis of our clinical, radiological, and histological evaluations, they determined that the lesion was in stage 3 and the patient was referred to an oncology hospital. After undergoing surgery, she was treated with radiotherapy and chemotherapy. Oral cancer is an important health problem worldwide, and according to the World Health Organization, oral cancers have increased in the past few decades. And as we saw in 2 patients in the present series, one of whom was a woman, their oral tumors were not associated with any habits such as tobacco smoking or alcohol consumption. So their presentations may be attributed to other etiological factors of oral squamous cell carcinoma, such as certain viruses, such as a human papillomavirus, low consumption of fruit and vegetables, genetic predisposition, and so forth. The survival ratio of patients with head and neck cancers is 76% in case of early diagnosis without metastasis, 41% in cases involving cervical lymph node metastasis, and 9% if there is metastasis under the neck region. Dysplastic oral mucosal lesion may develop into oral squamous cell carcinomas without early diagnosis and treatment. The survival duration of patients with oral squamous cell carcinoma may be linked to 5 years in stage 1 and 2 compared with stage 3 and 4. Patients in stage 3 and 4 are reported to have a mean 6 month or maximum 1 year survival duration. In terms of quality of life, survival probability, and treatment of the patient, early diagnosis of oral squamous cell carcinoma is very important. Dentists should have enough knowledge about clinical and radiological forms of anatomic structures to diagnose cancer in the oral region. Also, dentists should not overlook any abnormality in the oral region. One of the most important duties of a dentist is a good follow-up of patients, especially in the diagnosis period. If indicated, dentists should request a biopsy, and in the presence of metastasis, the patient should be directed to the appropriate related department.